The limping child can be a really tricky diagnosis to see in clinic, but we see it very often. And so this talk is going to focus on how to approach the pediatric patient with a limp. We're not going to talk about the objectives too much because, of course, we're going to be going over limping children, but this is a roadmap that I wanted to display to show where we're going to be heading on this lecture. So first, I want to kind of talk a little bit about how we get started on the limping child workup, and then we're going to talk more about the types of limp that you're going to see. Specifically, when you see limp, it can be kind of an all-encompassing term that actually, when we break it down, there are multiple different subtypes of limp that can help narrow your differential. We'll talk about some key physical exam findings and what you will specifically want to be looking for when you're doing an evaluation, and then the specific type of radiographs and parts of the body that you would want to image depending on what you find on physical exam. Hopefully through this process, you go from a person who may not know exactly how to approach this to someone who has a little bit more prowess and understanding of how to approach the limping child. And we all have stressors in clinic or stressors in the emergency department or urgent care that really detract from our ability to see a patient who may not be able to tell us exactly what's going on. Sometimes we have a flustered parent, or sometimes we have a child who just can't or won't react and follow instructions well. And so I always encourage people to take the limping child with an algorithmic approach, because when you look at the differential diagnosis, the list can be quite exhaustive. And when we really break it down and you start to think about it in a little bit more of simplistic terms, it comes down into these four subsets of categories. When we have an inflammatory process, we're thinking of like a reactive arthritis or rheumatologic process, maybe an infection, or you have an injury, something like a fracture and overuse. You could have an anatomic difference. Maybe there is a true functional leg length difference or a dislocated hip, or the weird things. And when I say weird, we're really talking more of like neoplastic processes, neuromuscular diagnoses, etc. But all of these types of categories can present with a simple limp. These can all be examples of patients who have simple chief complaints of limp that end up in your clinic. And the presentations can be quite vast. So when we approach the limping child, it's important to be aware of why we talk about this in the first place. The American Academy of Pediatrics notes that about 1 in 500 kids that present for an underlying concern will have some sort of limp as their chief complaint. And similarly, about 5% of ED visits are in tertiary care centers that manifest with a limping child. So if you think about this in a busy pediatric orthopedic institution, primary care, urgent care, this is going to come up almost weekly. So when we talk about a limping child, it's important to focus on what are the types of limp that you may see. And to recognize a limp, first we need to understand what the normal gait cycle is. Take a look at this blue leg that you're seeing on this patient right here, this example model. When we talk about normal gait, you can break down the gait cycle into two phases: stance phase and swing phase. And stance phase is simply when, from the time that the heel strikes the ground to when we load that leg and push through. And the swing phase is when we're not bearing weight and we're driving that leg through to repeat the next step in our cycle. And this is broken down to about 60% stance and 40% swing. And when you think about this, any alteration in the normal stance and swing phase gait cycle would result in some form of limp, whether that's painful or painless. For example, when you look at this type of limp, this is what we call an antalgic gait. Notice how this patient is walking with a shortened stance phase on their left side. As they swing through, they don't want to put a lot of weight on their left side, and so it looks like they have kind of a hitch in their step. This can be something that you see in kids as well, and pain simply shortens the stance phase. If you have someone who has an antalgic gait, it's critical to find where their point of maximal tenderness is. And in a child who can't exactly tell you what's going on, sometimes it's really helpful to ask the parents, like with a toddler, if they're simply able to crawl. This is called the crawl test, and it really helps to delineate where the pain or site of injury could be. So for example, if a patient can crawl but cannot walk, then that implies that maybe that the pathology is below the knee. If someone can't crawl or walk, then we have to be thinking more about the pathology potentially being in the knee or in the hip. You can also have patients that come in with a stress fracture that may not be apparent on radiographs, and sometimes taking a simple tuning fork and causing vibratory stress to that bone can produce pain and help you get a better understanding of a possible stress fracture. And then individuals who come in with a toddler fracture, we have that toddler who maybe have gone down the slide, their leg got caught, the radiographs are negative. Sometimes with direct palpation, they don't tend to withdraw, but rotating that leg, adding a little bit of stress to that tibia can actually produce some discomfort and guarding. In contrast to an antalgic gait, you can see something like this. Notice how this patient is walking, and when they step on their left side, they really kind of bob up and down. They hitch up and down. And this is called a vaulting gait, right? Or a hemiplegic gait. And how we describe vaulting is that one leg is shorter. Now, I put shorter in quotes because it could genuinely be that this patient does in fact have a leg length difference, like in a hemiparesis or a congenital limb length difference, but it could also in fact be simply that there's a lever arm dysfunction, and so maybe one side is weaker. Maybe that the hip is dislocated on one side, and what you're seeing is that they are compensating for that quote unquote shorter limb when they walk on that longer leg. You can also see when they walk on their shorter leg, sometimes they will actually circumduct or swing that long leg in a circle to clear the ground. This is also something that could be considered a type of limp. This is called a crouch gait. And notice how the patient is walking with their knees bent, their feet externally rotated. And I want you to imagine what it must feel like to walk in this squatted position all the time. This is a dysfunction in gait with respect to the plantar flexion knee extension couple, meaning that when we go to push off, we can't appropriately plantar flex or we can't appropriately extend our knee. And this is a compensatory mechanism to keep our center of gravity upright. We classically think about individuals who have over-lengthened Achilles tendons after a procedure, and that in turn, in order to keep their center of gravity upright, that squatting mechanism keeps their quads on all the time. And so this can actually be very energy inefficient, and oftentimes is, and it's really a devastating consequence for patients. Or maybe when you have someone who comes in with an apparent limp, what you're seeing is that they're walking on their tiptoes like this. This is what we call an equinus gait. And when someone's walking like this, it could be that they have pain in their heel or pain in their foot, or it could be simply that they have such tight Achilles tendons that they simply can't get their heels on the ground. And this is oftentimes a neurologic etiology. When you look at this patient who's walking up and down the hallway, another different type of limp that we have to consider is one that involves shoulder sway and kind of this waddle to their hips. If you take a peek at their shoulders and you notice how their shoulders are swaying side to side, you can see that this is what's called a Trendelenburg gait. Trendelenburg gaits are classically simply that the abductor musculature of the hips don't have an appropriate lever arm strength. So the muscle is used to contracting at a certain length, and deformity of the femur or abnormal location of the femur can lead to abnormal contraction, leading to difficulty with maintaining pelvic stability. And in order to maintain your center of gravity, the shoulders will sway. So when you think about the types of gait, that can certainly be one mechanism to help narrow your differential diagnosis. You can know that if someone has an antalgic gait, this could be trauma, this could be an overuse injury, infection, or maybe even a neoplastic process. If you have someone who similarly has an abductor lurch, we think about hip dysplasia or maybe hip abductor weakness. But you may in fact not be the type of person who recognizes gait abnormalities to help narrow their differential diagnosis. And if that's the case, if that's you, maybe what would be more helpful is teasing out instead the age demographic for who presents classically with different diagnoses. And that can sometimes be more helpful as well. So now that you know what some of the types of limp are that we're going to be classically seeing in the patient clinic, we have to talk about physical exam and how we're going to approach this patient in an algorithmic fashion. And an exam is not always hands-on with a child. Sometimes you have a pediatric patient who's upset, who's fussy, or who has stranger danger, and they don't necessarily trust you. And in that instance, it's really helpful to watch and observe as you're talking to the parents. What is the child doing? Are they in pain? Are they climbing around the exam room without difficulty? Are they bouncing up and down off the walls? That can tell you a lot about what you might be dealing with. And your parents are your source of trust for the kids. So again, if someone has a lot of stranger danger and they don't trust you, sometimes having the parents palpate the extremity that they're concerned about to see if the child reacts can be really helpful. Patients' actions can be a lot more valuable than words, especially in toddlers who maybe can't communicate as well with what's bothering them. And what I mean by that is look at their face when you're palpating. Sometimes all you see is a little wince or a guard, or they withdraw ever so slightly. We'll talk about Hilton's Law, and I talked about the crawl test earlier, specifically for toddlers to help differentiate where the source of pain may be, whether that's the hip and the knee or below the knee. In any pediatric patient, knee pain or complaints of knee pain means that the hip pain has to be examined until proven otherwise. Knee pain in a pediatric patient guarantees a hip exam due to Hilton's Law, which I'll explain in the next slide. And then we can't forget the spine. Sometimes what you're dealing with is early onset of discitis or a spinal infection, and sometimes all you see is they walk abnormally guarded, or they may even have pain when they go over speed bumps in the car. John Hilton was an anatomist in the 1860s who came up with this principle about essentially what we call referred pain. And so he came up with this idea that said nerves that supply a muscle that acts at a given joint must therefore also innervate that joint and the adjacent skin. And so this is why we typically will use blocks in anesthesia. It's also why the obturator nerve typically will run past the hip and manifest as knee pain. So someone who has a hip pathology, like a skiffy, for example, may in fact only present with knee pain. And so this explains why it's critical if you have someone who comes in with knee pain to assess the hips. So you may be thinking, all right, well, that's all great information, but where do I start with my physical exam? And we have to go back to the pediatric orthopedic basics of how to work this up. Take a systematic approach. Start with having them walk around the exam room, walk up and down the hallway. It can be critical, and it's easy to do for about 30 seconds. We can then tailor our exam based on what we find on gait through a hip exam, knee exam, leg and foot and ankle exam, and then a neurologic exam. So when we have someone walk up and down the hallway and we first start assessing a pediatric patient, we want to be doing a rotational profile. This can tell you a ton of information in a short amount of time. We're going to be looking at the foot progression angle. That is to say, if you draw a line straight in front of you between your feet, how do the feet hit in space relative to that line? If the feet point away from that line in the center, it's external foot progression. If the feet point towards the midline, that's internal foot progression. And so we want to check for symmetry, because if you have asymmetry, maybe we need to be worried about a tibial or a hip pathology. You want to check hip range of motion, especially when they're prone. Any type of asymmetry in the hip exam should warrant evaluation for hip pathology. And then, of course, we can check generalized strength through toe walking and heel walking. And then we can check duck walking to assess their quadriceps strength. As we start to work our way up, so if you're worried about a hip pathology in toddlers, you could think about in our children under 3 months of age, we think about Ortolani and Barlow as being really helpful. But kids over the age of 3 months typically actually don't tend to have Ortolani or Barlow positive hips. And so what's more reliable is what's referred to as asymmetric hip abduction and the Galeazzi test. You can see here on this image on the left that this patient can abduct their right hip very well, but the left hip does not move very much. Similarly, when you look at the middle image, you can see that when you put the knees together, the left knee is shorter than the right. And both of these findings suggest a unilateral hip dislocation until proven otherwise. Always look at a patient, especially a young toddler, how they're standing. If they're standing with accentuated lumbar lordosis, meaning that they're arching their low back excessively, you want to think about pelvis films, because that can be a pathognomonic sign for a bilateral hip dislocation. And in older kids who can maybe cooperate more with an exam, certainly you want to be worried about things like a slipped capital femoral epiphysis. These kids will tend to have unilateral asymmetry in their foot progression when they're walking. Someone will have one-sided external foot progression angle. And you can also check for hip abductor function or dysfunction. You can use what's called the Trendelenburg sign, which is different from a Trendelenburg gait, by having them balance on one leg, and they should be able to stabilize their pelvis and keep it level. If you look at this patient on the right side of the slide, you can see that the middle image shows green lines where the patient is balancing on one leg, and they're able to stabilize their pelvis well, meaning that their hip abductors are firing appropriately. On the image all the way to the right, the other side, on the other hand, does not have adequate hip abductor function, and so we can't stabilize the pelvis appropriately. The pelvis droops down on the patient's right, causing them to shift their shoulders to the left to maintain their balance. And then, of course, if you're worried about a skiffy, there's something called obligate external rotation inflection. And if you look at this patient right here, the image all the way to the left with the straight red arrow shows that when you flex the hip up and down while the patient is laying down, they should be able to flex to at least 90 degrees without difficulty. But if you're worried about a skiffy, a slipped capital femoral epiphysis, note the image to the right with the curved arrow. What you'll see is when the patient tries to flex their hip, they can't flex their hip beyond a certain point without externally rotating the hip. And that's because of the pathologic and anatomical alignment of the slipped capital femoral epiphysis. As you start to tease out, maybe this isn't a skiffy patient, maybe instead what you're dealing with is some capsular laxity or some impingement, or maybe even some residual dysplasia that's gone undiagnosed in an adolescent. And so you want to do a hip rotational profile, not only prone, but then also when the patient is supine. When the patient is prone, it really helps to isolate the femoral torsion or the twist of the femurs, while supine can actually tell you a little bit more about acetabular impingement or acetabular alignment. This can be helpful for things like FAI, CAM, or pincer lesions, or it can also be helpful for hip dysplasia if they have tons and tons of internal rotation. And then, of course, you want to do your Faber and your Fadir. That's your flexion, abduction, external rotation test, or your Patrick test. And then your Fadir test, flexion, adduction, internal rotation, to feel for any feelings of impingement. And then you can tease out more special tests depending on how nuanced you need to get. When you're looking at the knee and the leg, it's really important to monitor for any signs of effusion or atrophy. The image on the left-hand side with the two red arrows points out where the VMO muscle is, and you want to be assessing for any signs of atrophy there. Individuals who have atrophy of their VMO may have maltracking of their patella, and so then as a result, maybe they had a patellar instability event. Maybe they had a patellar dislocation that spontaneously reduced. Additionally, what you can do is sometimes you can milk an effusion. So by taking the suprapatellar region and adding pressure, you may shift fluid into the patellar region and recreate that obvious boggy effusion. And that can be really helpful in guiding what may have happened. Is this traumatic? Is this infectious? Etc. Of course, you want to do your stability tests where we do our Lockman assessment on the image all the way to the right. And then you check your collateral ligaments with knee extension. And then patellar apprehension. Remember how I said if you're concerned about a knee effusion or a patellar instability event, pushing the patella laterally can create this feeling or this reproduction of the patella going out of the trochlea. And that in turn can create apprehension for the patient, meaning that they don't want you to do that and they sort of respond and say, please don't do that, that hurts. When you're talking about point of maximal tenderness, it can actually be very nuanced, but incredibly helpful. And this chart is something that I find incredibly valuable for patients and for people who are learning about knee assessments. So depending on where the knee arrow point of maximal tenderness is, can help guide your thought process to the differential of what's going on with the knee. In the foot and ankle, we break down the abnormalities depending on what the lateral border of the foot is doing, what the arch is doing, and what the hindfoot positioning is doing. Always look at the shape of the foot because the foot shape itself can actually point to the problem. And what I mean by that is oftentimes if someone's complaining of pain or a limp, in their foot and the arch is flat, well, maybe the problem is in fact that they have a pathologic foot shape that's a flat foot. Conversely, if their arch is really high and they're complaining about foot pain, it could in fact be that the arch is above, or the problem is above where the main complaint is. And so when you have a really high arch in like what's called a cavovarus foot, we want to think about brain and spine pathology. Calluses and shoe wear can tell you a lot about where the patient is bearing most of their weight. So if you have someone like in this top right image who has a really thick callus at their midfoot, it's likely that they're actually bearing a ton of their weight at their longitudinal arch, and maybe this is actually a symptomatic flat foot. And then, of course, it's important to measure their flexibility of their Achilles tendons, because if they're having calf pain or they're limping, they may in fact have tight symptomatic Achilles tendons. But the great part about the foot and ankle, just like the knee, is that points of maximal tenderness in anatomy can really tell us a lot about what the differential diagnosis is. And this is one of my favorite images for learners to help get a better understanding of where the pathology may be and what the pathology may be depending on location. I did mention earlier to assess for this hyperlordosis if you're worried about dislocated hips, but also it's making sure this could sometimes be a splinting posture to help offload an area that is in fact inflamed in an early infection or maybe even a tumor. So palpating the spine and checking range of motion is critical. In the orthopedic world, we want to be thinking about our neurologic exam, and at the very least, you want to be assessing their reflexes, the patella, the Achilles, and then what's called clonus. Notice how you can see in this top right image, this patient is having their foot jarred up abruptly, and they have this involuntary kickback that's going on. Similarly, in the bottom left image, you can see that this tap is very, very robust. They can kick very strongly, and you want to really be assessing to make sure, number one, is that symmetric, right? If it's not, then we want to be worried about a neurological abnormality. Some people are, in fact, a little bit more hyperreflexic, but in the setting of a limp, really, especially if there's a unilateral abnormality, you have to be concerned about a neurologic finding. In pediatric patients, clonus, sometimes if they are very responsive, you can have a few beats of clonus. So I would say 2 is normal, but any type of sustained clonus or any type of unilateral clonus is abnormal and needs to be appropriately worked up. So let's talk a little bit about some of the radiographic findings that you might think about. I had a mentor, or actually a couple mentors, that when I was first starting told me about what's called the 30-second rule in imaging. And this is when you get outside images from another institution and you're looking at them, but you haven't seen the patient yet. If you really haven't seen any obvious pathology jumping out at you, go see the patient after 30 seconds. You'll get a lot more understanding of what may be going on than by simply just looking at the images. And the types of images that you order are really guided by your history and your physical exam. And the reason I say that is because more images are not always better, meaning that they don't help lead you to the diagnosis that you might be suspicious of. So thinking about what you're ordering can be really helpful. Of course, sometimes it's really obvious why a patient has a limp, right? Inevitably, if you have a patient that comes in with a limp and this is what you see on a pelvis film, then we know that the source is likely due to their lack of a femoral head, probably due to an ongoing or a history of infection. But sometimes it's a little bit less obvious. And so we start with the pelvis. If you're worried about a hip pathology, in pediatric patients, it's very valuable to order an AP and a frog of the pelvis, and less valuable to order isolated hip films. The reason being is because the femoral physis, or the growth plate of the femur, can be abnormal, and it can be very subtle, especially in an early SCFE, slip capital femoral epiphysis. And so ordering an isolated hip film may in fact make you miss a subtle early SCFE. So ordering a pelvis can be very helpful. Sometimes people will ask, why not order a 4-view versus a 2-view if you work at an institution that deals with hip dysplasia in adolescence? And really it's a matter of the type of pathology that you're thinking about. So you want to be thinking, if you're worried more about an impingement, or you're worried more about a dysplasia that's residual in like a teenager or a young adult, you want to be thinking more about their 4-view hip preservation series, where other things may just be simple to start with an AP frog of the pelvis. And we want to go through a systematic checklist when we're looking at pathology in the hips. So what I mean by that is look at the femoral head shape. Is it round and is it symmetric to the other side, or is one side rather irregular? Look at Klein's line. And Klein's line is along the superior margin of the femoral neck, and it should traverse the femoral head, which I'll show you later. Shenton's line is a line along the inferior margin of the femoral neck, and it should contact and make a confluent arch with the pubis. You want to look at the head-neck junction to see if there's any abnormal widening, shortening, or lengthening, and what the angle is. And then you want to look at the joint space widening. And so in this example right here in this patient, the yellow arrow is looking at the sourceal, so the acetabular roof. And you can see in this patient, compared to the right side, the patient's left side is irregular and upsloping. You can see the teardrop here, the red arrows, is also rather widened. It's sort of U-shaped compared to the other side, which is more narrow. Shenton's line in green is broken, so we don't have a nice confluent arch, but rather you have this irregular contour of an arch. And then if you look at the orange line, you can see that the joint space is widened compared to the other side. And this is a patient who had residual dysplasia that began to become symptomatic. But it's important to get not just a single view. You want to think about AP and frog films of the pelvis, because sometimes what you might see is you might actually see early fragmentation for what's called leg calf Perthes disease. And this is apparent on the patient's image to the right, which has that lucency underneath the femoral head where the red arrow is. This is called the crescent sign and may in fact only be visible on the frog film. Compare that to the left side, this AP, where this individual has ongoing leg calf Perthes disease, and you can see the collapse of the femoral head on the left compared to the right. Klein's line is your anterohumeral line of the hip. So if you deal with any type of elbow fractures and you're constantly drawing the anterohumeral line, Klein's line is the hip equivalent of that. And so if you have a patient who has hip pain and you're getting an AP and frog films of the pelvis, always draw Klein's line. It should be transecting the femoral epiphysis in all images. And you can see here this patient's right side, the Klein's line is intact, while the left side Klein's line is broken as it does not transect the femoral epiphysis. For the knee films, it's great to start with a 2-view, just a simple AP and a lateral. And you want to be checking more about our checklist. What is the patella doing? Is it sitting where it's supposed to be? Is it too high or is it too low? What do the femoral condyles look like? Are they nice and circular? Do they have good, excellent contour? Are they superimposed on one another? Or is it maybe an abnormal projection of the condyles? Is there anything in the joint? And then, of course, one thing that is essential is to always look for what's called a second lesion. If you're thinking more about an osteochondral defect, or you're thinking more about patellar instability, then adding more films such as a tunnel or a sunrise view can be helpful for you. In this instance, you can see in the third image, the patient has a tunnel view of the knee, and you can see this loose, unstable osteochondral defect on the lateral femoral condyle. And then the sunrise film all the way to the right would be great to see how the patella is tracking in the trochlea of the femurs. As you start thinking, I mentioned it's incredibly important. As I mentioned earlier, it's incredibly important to monitor and comment on whether or not you are worried about a second lesion. This is a bony fleck off the proximal lateral tibia, and if you see this in about 75 to 100% of cases, it's pathognomonic for an ACL injury. So you really want to be worried about a second lesion and monitoring for those. As we start to work our way down towards the tibia and the fibula, it's standard to start with an AP and a lateral film. I don't tend to order oblique films of the tibia, particularly in toddlers, for a toddler's fracture, because it's usually not diagnostic. The clinical exam is much more diagnostic, and it doesn't change what you do. Look at the cortices of the tibia. Make sure that the cortices aren't abnormally thickened. They are typically thick in general, but you want to make sure that they don't have excessive robustness of the tibial cortex. As you can see here on this image on the right, there's a nidus here, because sometimes what they may have is they may have something like an osteoid osteoma. And it's also really important if you have someone who has an ankle sprain or an ankle injury in a pediatric population to really make sure that you're getting tib-fib films and making sure that you're not missing a fibular head or proximal fibula fracture, something like a Mason-Neuve injury. As you start thinking about ankle and foot pathology, it's critical to remember that ankle pathology and foot pathology cannot be appropriately diagnosed without simulated weight bearing at the very least. But if they can bear weight, we want to think about weight bearing foot films or weight bearing ankle films. And when in doubt, starting with an AP lateral and mortise film of the ankle and AP oblique lateral films of the foot are very helpful. You want to look at what the ankle mortise is doing and what the medial clear space looks like, and making sure why one of the reasons why we get simulated weight-bearing films, even if the patient is having difficulty bearing weight, is because the medial clear space can appear abnormally widened in a plantar flexed foot. We want to look at the overlap of the tibia and the fibula and the clear space between the tibia and the fibula on our ankle films. For the foot, we want to see how the alignment of the arch is doing. We want to see what the growth plates are doing and what the apophyses are doing, or secondary growth centers. Sometimes it's better visualized. The ankle mortise can be better visualized for pathology compared to the AP film, as you can see here on this talar dome osteochondral defect. For the foot, it can be really helpful to check what the calcaneal apophysis is doing, as in this top right image. If it's fragmented and irregular appearing, maybe they have Sever's apophysitis or calcaneopophysitis. It's also very helpful to look at the shape of the bones in general. As you can see in this bottom left image, there's fragmentation and collapse of the navicular, consistent with Kohler's disease. Or maybe where they have point maximal tenderness along their medial longitudinal arch, you in fact see this floating bone like an accessory navicular, and that can be the source of their pain. And then, of course, if you're worried about a tarsal coalition, sometimes what you see is confluency between the navicular and the calcaneus, or the talus and the calcaneus, through the C sign of Latour, or the anteater sign, which is elongation of the calcaneal process. So we talked about all this stuff, and in short summary, the differential for a limping child is very large, but a pointed history and physical exam can really help tailor your differential. Always start with a good history and exam before you order any imaging, as it can really help guide your thought process. And think about the most common pathologies in pediatric patients, chasing horses before zebras. And using an algorithmic approach for radiographs and for physical exams can really help you avoid missing bread and butter diagnoses. Thanks so much.